right, party people, let's get it. So let's say I give you a dude who's in his 30s and he has a 6-month history of muscle aches and fatigue. He had a kidney stone about a year ago and a T99 scan shows a nodule in the central neck. What are we thinking about? 3, 2, 1, boom. Men 1, pituitary tumors, parathyroid, hyperplasia or adenoma, and pancreatic tumors. You have to know this. You might be asking, oh, why aren't there any signs of pituitary or pancreatic involvement here? And that's easy, because the USMLE does not have to give you a complete constellation for you to make a choice or to come up with a diagnosis. They can give you 2 out of 3 or 1 out of 5. Usually they'll give you at least a couple to be able to connect the dots. But really, at the end of the day, this is about picking the best possible choice out of the information given. And based on what I provided you, this is that choice. Rett wasn't listed, and I'm going to explain why. MEN2 syndromes involve Rett. You have MEN2A and MEN2B. In the case of MEN2A, that includes medullary thyroid carcinoma, pheochromocytoma, and parathyroid hyperplasia/adenoma. MEN2B, on the other hand, has medullary thyroid carcinoma, pheochromocytoma, mucosal neuromas, and marfanoid habitus. Think of a tall, lanky dude with arachnodictyly, long, lanky fingers. Since MEN2A involves the parathyroid, Rett technically could be a possible answer choice for this question. However, I did not provide it to you, so therefore we're rolling with MEN1. I'm not trying to bamboozle you or trip you up. Let's run through the other possible options and sharpen up your understanding. FBN1/FBN2, this would be associated with Marfan syndrome. Mutations affect fibrillin, and this forms a sheath around elastin, not collagen. Just to review, signs of Marfan include tall stature, arachnodictyly, chest wall deformities, pectus excavatum/carinatum for you Latin enthusiasts, flat feet, aortic aneurysms, and mitral valve prolapse. There is no increased risk of Barry aneurysms. That's for Ehlers-Danlos. Do not mix these up. And it's not relevant here because there are no Marfanoid features in the patient I gave you. Next up, we have NF1. This is neurofibromatosis type 1. I want you thinking café au lait spots. These are hyperpigmented macules. Axillary and groin freckling. You have obviously neurofibromas. Leash nodules. These are iris hamartomas, pheochromocytoma, and CNS tumors. Ependymomas, oligodendrogliomas, and again, not related to parathyroid disease. Then we have neurofibromatosis type 2. Here you're going to have bilateral acoustic schwannomas. They don't have to present at the same time. Once again, they can show up one at a time, but just know that this is how you recognize it. Bilateral acoustic schwannomas are connected to NF2, as well as meningiomas, and again, not related to parathyroid disease. Next up, we have VHL, von Hippel-Landau disease. Here you will have retinal and cerebellar hemangioblastomas. Also, renal cell carcinoma, and can be bilateral, doesn't have to be. This mutation leads to constitutive activation of hypoxia-induced factors, resulting in increased angiogenesis. And again, not associated with parathyroid pathology. And just as a fun review of the chromosomal associations for bonus points, here we're going to have MEN1 associated with chromosome 11. We have Rett on chromosome 10, NF1 chromosome 17, NF2 chromosome 22, VHL chromosome 3, FBN1/FBN2 on chromosome 15. That again is Marfan's. That's it for this one. Go crush it.